No, it's my pleasure to invite to the lectern Christoph Venner, who doesn't need any introduction, but perhaps you don't know that he's one of the first nephrocardiologists in the world. So we just discussed over coffee that nephrocardiology should be introduced as a subspecialty to be recognized. And I'm really glad that Christoph not only is based in Würzburg, Germany, but also is a visiting professor in Prague at our medical school. So it's our great honor, and we are very happy to have him, as we are happy to have you here, and now to move to other microvascular complications in kidneys. Thank you very much, Christoph.
And different from a cardio-nephrologist, nephrocardio. So thank you for the invitation. I really remember the first days and followed all the years argue by. The first days when you asked me, can we understand the 4D results better? And over the years, I came now to another field, and here is Würzburg actually, many years ago, and we were looking already at urine. Würzburg, here the castle, and at this time we did the foam test to detect albuminuria or proteinuria. We also tasted the urine for glucose, and these were the only tests. Yeah. Many years later then, I think I used then, I have to show this before, and then many years later we saw the first results and an educational booklet from Hermann Senator when he was at the Charité in Berlin, and he described albuminuria in health and disease. At the same time, Dr. George S. Bach, invented his albuminometer, where he was looking at albuminuria in a test in a tube filled with urine, and this is the S-Bach albuminometer from 1874. So he used his reagent, picrinic and citric acid, and then he saw a yellow precipitate and the first detection method for albuminuria. Now we do it differently in these days, and we are looking on a clinical picture how albuminuria is developed. Early on, the kidney is going into hyperfiltration, and then the GFR drops. At the same time, albuminuria, but also very, very early, comes up, and here we are in the nephrotic range, albuminuria, a picture we don't see anymore today because we can influence this development by lowering pressure in the glomerulus and by avoiding hyperfiltration, and we have medications for this. And we are acting relatively late currently in this stage with our medication, but I think the future should be to move into earlier stages when albuminuria is present. We do not understand completely this trajectory, but to lower hyperfiltration and protect the microvascular system and the kidney. So going earlier means that we want to prevent damage, and I think it's a bit delayed always, here. Because we want to prevent end-stage kidney disease and cardiovascular death. And this is a meta-analysis of 30 cohort studies with nearly 1 million people by Dr. Fox and Joe Koresh. And they showed that the albuminuria, UACR, urine albumin creatinine ratio, when it's coming out of low normal into the microalbuminuria and then macroalbuminuria, it predicts end-stage kidney disease. Here is the adjusted hazard ratio. And also predicts cardiovascular death. There is a difference in these two cartoons, that cardiovascular death levels off very early with traces of albuminuria, and the kidney really comes into the play when more albuminuria, around 200 to 300, is poured out through the urine. So there are different mechanisms on the way which we really do not understand completely so far. And recently there has been some models to explain the compression model when we have here the glomerular basement membrane, the podocyte is playing a major role, and the capillary lumen with the endothelial cell layer. And when you move from healthy to diseased stage, then through the endothelial layer, through the basement membrane, albuminuria is leaking into the urinary tract, and there the reabsorption capacity in the tubular lumen is also overwhelmed, and then we develop albuminuria. So this is the compression force and fluid filtration model recently suggested. And overall, the lower stages of categories of albuminuria in the range of 30 to 300 milligram per gram UACR is also going on a different mechanism. And there are experiments out there that the lower ranges of albuminuria is also an indicator for generalized endothelial cell dysfunction in patients with generalized cardiovascular disease or the metabolic syndrome. And the underlying cause appears to be an early glycocalyx dysfunction and degradation connected to a reduced NO synthesis. So the cardiovascular continuum with this mechanism, and then with higher albuminuria, the kidney continuum, is the current understanding of albuminuria damaging the kidney and the cardiovascular system. So let's go from these 1 million people data sets by Fox and colleagues to the heat map the KDIGO, Kidney Disease Improving Global Outcome Guidelines, have generated already 10 years ago. And they have shown us, if you take not only albuminuria here from this category A1 to A2, A3, this was previously called microalbuminuria, and macroalbuminuria, we want to go away from micro because it's not a micro, it's not harmless, to move into categories, and then stages of chronic kidney disease with the glomerular filtration rate. And you have progression of kidney disease when you have high albuminuria and lower ranges of kidney function. But one thing, and this is now given here in blue, goes undetected when you only measure kidney function by glomerular filtration rate. You need to have albuminuria co-measured with glomerular filtration rate to detect these early stages of damage and of the kidney where we want to intervene. And albuminuria is a problem in the general medicine. It is not measured very often. It is neglected or forgotten, and the current SGLT2 inhibitor introduction into treatment and non-steroidal mineralocorticoid receptor antagonism, they favor to detect these patients in these categories of albuminuria and kidney function to bring the new medications to the patients and prevent further progression. So since it is neglected and since there are barriers out there, for example, in the cardiology outpatient clinic, they never measure albuminuria. They don't want to deal with this yellow stuff in their outpatient clinic. Yeah? Just very basic practical aspects. The kidney community now wants to move the albuminuria testing into a home test, point of care type or home test, and the patient should be responsible. And there are some possibilities. For example, you handle out the patients this test tube, and there is a hygroscopic polymer here, and he can send this to the central laboratory. There was a study, the Thomas study in the Netherlands, in 15,000 people, comparing this central laboratory test with a new test which is coming along with an app and you have here the albuminuria, and you put them here into, and you use an app, and then you can see your albuminuria result directly on the app and can transfer it to the physician. So these two tests were compared in the Thomas study, presented, not yet published, and on the left-hand side is the classical method, urine collection tube. In overall 15,000 people called, and 60 of the general population, and 60% responded, women versus male, the elderly versus the younger ones. So overall, the response to participate in this study was pretty high when you call 15,000 patients from a region. The e-health method by the app had a little bit of a lower acceptance rate, and even the elderly, they were even lower than the, for example, the classic method. Maybe this type of people were not so familiar with the app, and overall there was a 50% response rate, and they could detect about 5% albuminuric patients from the general population, which were also then remeasured in the laboratory. So when you go into the general population and screen them, you have about 5% of people with chronic kidney disease measured by albuminuria. So, and then we recently saw a paper in Lancet Diabetes Endocrinology, the change of albuminuria, which is a surrogate endpoint marker currently for progression of kidney disease. And here a meta-analysis from the treatment of randomized clinical trials, 29,000 people, 41 comparisons of treatments in RCTs, which they collected to test this hypothesis. And here you see all these trials, and some are familiar with you: the PREVENT, the ASK trial, ADVANCE, RENAL, IDNT, intervention trials with losartan and irbesartan, the RAIN trial, famous trials in nephrology taken all together, meta-analysis of these trials, and you see the albuminuria, urinary albumin creatinine ratio in the morning spot urine is connected to the annual renal event rate for end-stage kidney disease, a very good linear relationship. And therefore, the albuminuria here in this is clearly associated with kidney failure in different population RCTs and cohort studies. And because of this work and others, the FDA now approved albuminuria as a surrogate marker in phase 2 trials, and the EMA as well. So in this trial also, albuminuria with a biological plausible effect as a surrogate marker was significantly associated with a therapeutic effect on clinical accepted endpoints, and a strong effect was visible with a UACR above 30 milligram per gram, and an even stronger predictive effect when the reduction of albuminuria was more than 30% of the intervention. And the approval from the FDA for interventions in phase 2 trials is when an intervention has more than 30% reduction in albuminuria. Here is another analysis of trial level for the treatment effect of UACR and clinical endpoints. And I show this because I was asked to bring the EMPA-REG outcome data, and here for the first time empagliflozin is here in this trial, and it fits perfectly in this treatment effect on UACR and clinical endpoints. Another medication which just a couple of months ago was approved and came to the market is finerenone, non-steroidal mineralocorticoid receptor antagonist, which protects the kidney. And here you see that also this intervention has a 30%, more than 30% reduction of albuminuria in various categories, and this is a prominent sample size, and the Fidelity and Figaro trials were positive in reduction of the kidney outcome, and here the analysis for Fidelity showing that this translates, or UACR or reduction translates then into the hard clinical endpoint. So next thing is the change in albuminuria and eGFR slope. Now kidney community wants to see the two function and damage assays, the eGFR slope and albuminuria, being combined as joint surrogate endpoints for kidney failure. And this is work in progress. As you know, that showed you the studies demonstrated the treatment effects on change in albuminuria and on GFR slope. And therefore, a conceptual framework in these manuscripts in press was developed that combined both surrogate endpoints, UACR and eGFR, to better predict treatment effects on clinical endpoints in phase 2 trials. And the results of this data analysis was that information from a combined treatment effect on albuminuria and eGFR slope does improve prediction of treatment effects on the clinical endpoints for phase 2 trials if you have a sample size between 100 and 200 patients ranging for 1 to 2 years. I think this is important to see. Many of the current drugs tested in phase 2 in smaller sample size, rare diseases, they do not include 200 patients for at least 2 years. And this analysis clearly shows you that's important. If we go into the EMPA-REG outcome trials, we saw that if you have a patient with normal albuminuria or microalbuminuria, the progression rate of people with cardiovascular disease on the kidney with low-grade albuminuria is rather slow. It is there over a period of 3 years. Only when you develop macroalbuminuria, you lose about 7 ml per minute per year, and you reach end-stage kidney disease in a short period of time. If you go into the lower progression rate areas with micro or normal, it takes a long, long time, or you have to use large sample sizes. And we saw a similar example when we analyzed the EMPA kidney trial, which we published just a couple of weeks ago. And if we were looking in a pre-specified analysis in UACR categories, and EMPA kidney had people with low eGFR but with normal albuminuria included, and there were a substantial number of patients with normal albuminuria, micro or macroalbuminuria. And it appears that the intervention is especially effective when you have macroalbuminuria. And there is a trend p-value which you can say that it's less effective in people with low albuminuria. On the other hand, it's difficult to interpret results in a trial which was stopped after 2 years in a short-term trial when you have a low progressive sample of patients with no albuminuria. They are clearly low progressive, as I showed you in EMPA-REG outcome. But if you look into another analysis in people looking at eGFR slopes by categories of albuminuria, then you can see in those with normal albuminuria, the intervention is effective, reducing the difference of the placebo group, 0.89, to about 0.11. So a null slope. And this is, so you get a reduction in albuminuria. When you look at slopes, when you look at hard outcomes, kidney disease progression with dialysis, you cannot see it in the 2-year intervention. For me, this is especially interesting because you reduce here the slope into a null slope, which I've never seen in my history, because usually when you are above the age of 45, you lose around 0.65 ml per minute per year by aging. So the intervention, an SGLT2 inhibitor, reverses the natural course of aging, or how could we interpret it? This figure here, this result. So for our general practitioners, I designed this cartoon recently, and with EGFR, when you measure or calculate EGFR, you can say the patient's during his life, progressive life towards the cliff is dialysis, and when you have him with an EGFR of 90 or 60, you can say here he is in his current stage of progression of his life. But if you, in addition, use UACR and you have low or high UACR, you can determine the speed the patient is travel towards the cliff. So I think these things are necessary to talk to our colleagues, primary care physicians, to make them understanding the differences between micro transitioning to macro, the speed and the damage which occurs to the microvascular system in the kidney. What do guidelines say? European Society Cardiology guidelines say that it is recommended the patients with type 2 diabetes or diabetes mellitus are annually screened for kidney disease. It's a 1A level recommendation, and also American Diabetes Association is in, and the kidney guidelines are in accordance. So the current cardiovascular guidelines in the European Society of Cardiology have taken albuminuria and EGFR into the risk assessment, blood pressure, cholesterol, and diabetes. And according to some doctors, it would be the best that if the patient's one timing asking you, doctor, what is my A, B, C, D, E, and albuminuria is taken into the cardiovascular risk assessment of the patient. So I think I'm coming now to the end and make a summary that there is a biologic plausibility that albuminuria is locating on a pathophysiologic pathway which is leading to loss of kidney function and development of atherosclerosis. Experimental data, observational studies, and post-hoc analysis of RCTs link albuminuria to renal and cardiovascular prognosis and the changes in albuminuria with a change in prognosis. The early changes in albuminuria are interconnected with long-term kidney risk independent of the underlying population, and association studies are always, we must say, subject to bias because other known and unknown risk factors often work independent of lowering albuminuria, and they may have influenced the low risk of kidney outcomes such as blood pressure lowering. And overall, it appears that albuminuria is a valid surrogate marker for kidney outcome, and we may have to work more in this area. So I thank you very much.